Acute pleuritic chest pain. The majority of patients with chest pain referred for a respiratory opinion have either acute pleuritic pain or persistent, well-localized pain. The pleuritic chest pain is sharp, well-localized, worse on coughing and inspiration, and the subsequent limitation of inspiration often leads to a degree of breathlessness. Causes of acute pleuritic chest pain include the following: pulmonary infarction following embolism, pneumonia, pneumothorax, pericarditis, pleural infection such as emphysema or tuberculosis, autoimmune disease such as systemic lupus erythematosus, rheumatoid arthritis, musculoskeletal problem, fractured rib. In addition, we should consider a typical presentation of a serious condition such as myocardial infarction, aortic dissection, esophageal rupture, and pancreatitis. Consider also angio-invasive fungi such as aspergillus as a cause of pleuritic chest pain in the immunocompromised patients. Diagnosis is typically based on pattern recognition of clinical features followed by selected investigations. Initial investigations typically include chest radiograph, ACG, arterial blood gas, serum inflammatory markers, and D-dimers. Further investigation may include ventilation, perfusion, scanning, VQ scanning, or CT pulmonary angiogram, pleural aspiration, and the measurement of serum O2 antibodies. Pulmonary embolism, pulmonary thromboembolic disease, commonly presents with pleuritic pain, and exclusion of this diagnosis is the usual reason for referral. We should assess risk factors for thromboembolic disease. Normal autosaturations and PO2 in the normal range don't exclude the diagnosis. We should calculate the AE gradient, and the presence of a pleural rub is a non-specific sign that can occur with pleural inflammation of any cause. In young adults, pneumococcal pneumonia may present with acute onset pleuritic chest pain, although systemic symptoms such as fever usually predate the pain by hours. The pain from pericarditis is pleuritic but central and relieved on leaning forward. There may be also a pericardial rub, characteristic ECG features, and a small pericardial effusion on echo. Musculoskeletal pain may occur as a result of cervical disc disease, arthritis of the shoulder or spine, a fractured rib, or costochondritis, which often follow a viral infection. The presence of a chest wall tenderness does not invariably indicate a benign musculoskeletal cause. Tenderness may be seen in malignant chest wall infiltration and sometimes following pulmonary infarction. Other features besides pleurisy that may suggest diagnosis of systemic lupus erythematosus include rash, photosensitivity, oral ulcers, arthritis, pericarditis, renal or neurological disease, cytopenia, positive antinuclear antibody, and the double-stranded DNA. In chronic chest pain, persistent chest pain that is well localized is typically caused by chest wall or pleural disease. The causes may include the following: malignant pleural disease or chest wall infiltration, benign musculoskeletal pain, pleural infection such as emphysema and tuberculosis, benign asbestos-related pleural disease, autoimmune disease such as systemic lupus erythematosus or rheumatoid arthritis, recurrent pulmonary infarction such as emboli or vasculitis. And pain from malignant chest wall infiltration is often boring in character and may disturb sleep. It is frequently not related to respiration. Causes include primary lung cancer, secondary pleural malignancy, mesothelioma, and RIP2, external involvement from malignancy, including myeloma or leukemia. Chronic thromboembolic disease tends to present with breathlessness. When chest pain occurs, it is usually episodic rather than persistent. As with acute pleuritic pain, investigations are directed by initial clinical suspicion and consideration of CT chest, bone scan, serum autoantibodies, full blood count, and film, and serum electrophoresis and chest X-ray may appear normal in malignant chest wall disease.